Okay, welcome everyone. Thanks for joining. Emily, thanks for doing this. I'm excited to go through our quarterly policy review with you.
Always glad to see you too.
Yeah, it seems like a lot changes in a quarter, and yet a lot is, we'll circle back to some of the recurring themes too. So we have a little of both. Today, UnitedHealth Group came out with their earnings report. I know it's hot off the presses, so you may not have dug into both of them, but we wanted to use this opportunity to talk through that really in the frame of Medicare Advantage and how the demographics are shifting. We talked about it at the end of last year, but I think we continue to see changes and evolution. And of course, United came out today. So let's talk through the Medicare Advantage demographics and policy, and then have a couple other topics to talk through too.
Yeah, let's talk about what UnitedHealth Group did, because in terms of earnings for first quarter, which is pretty important. They were taking a big hit on the Change Healthcare. It's going to be over $1 billion in the end. But the way in which we do these things on Wall Street is we set those things aside that are one-time events. So when you set that aside, you had an adjusted first quarter earning of $6.91 versus $6.26 last year, and Wall Street was expecting $6.62. So that's a fairly significant improvement. Their revenue for the quarter was $99.8 billion, up from $91.9 billion last year, and the street was looking for about 99.28. So did a little bit better on the top line as well. And the reason this is important is, first of all, a lot of people were worried that the Change Healthcare debacle would create a cloud that would make it more difficult to see exactly what took place at UnitedHealth Group. We know, for example, that they dropped a lot of their prior authorization rules and their utilization management rules during this period, and they had a lot more utilization, but they're reporting a medical loss ratio, meaning what they paid out in benefits versus what they received in premiums, of 84.3%, which is fine. Of course, UnitedHealth is so big, we don't know what happens under the engine, but it's fine. So what was happening going into that earnings call was Wall Street is expecting a couple of things. First of all, they're expecting higher benefit costs, because we've heard from Humana, for example, say we're seeing higher benefit costs, particularly on the inpatient side. We've also, UnitedHealth Group has mentioned it, and so have a few others. Now, the interesting thing is, as Marcus knows, because I talked to him about this last week, I had a little bit of trouble finding, these cost issues, when I look at the data, and it looks like it's a problem, but it's primarily a problem between the Medicare Advantage plans and the hospital system. So, Marcus, if you want to, we'll throw up slide 2. This is the Medicare Advantage, adding kind of to the woes of the Change Healthcare issue, concerns about medical loss ratios, et cetera, is Medicare Advantage is kind of facing a bit of a demographic headwind. And I put a line, that blue line that you'll see on the slide, that's your month over month change. And you can see the little peaks are when the monthly enrollment spikes after the January. The open enrollment period. So You got the fall open enrollment period, and those people that appear on the rolls as a result of the open enrollment period. And what do you notice about the trend there since 2019, roughly?
Going down.
It's going down, and it's going down because there are the growth of seniors, people turning 65, is slowing. The last big post-war cohort is 1961-62, and they turned 65 in a couple of years, and from there it's a cliff, until we get to the millennials. So you have the the challenge here is that you have fewer people to recruit onto your roles, because of demographics. You have this benefit cost pressure, particularly from the inpatient hospitals. And we should also mention that your boomer cohort, which turned 65 in 2012, those people are hitting their top utilization cost years. So you've got this not great mix. The thing we all have to remember when it comes to publicly traded companies is that they have the biggest balance sheets. They have the biggest lines of credit, and there are all these other plans out there, Blues plans, smaller regional plans. And I keep reminding people, a lot of bad things can happen before it ever gets to the door of the large managed care organizations. And that from this earnings, that appears to be the case. We need to hear from Humana. Humana is pure play Medicare Advantage, not unlike UnitedHealth Group, and we want to hear what they have to say. And one of because they've expressed concern about their benefit ratio, at the same time that I'm going, yeah, it's up, but shouldn't be too different from fourth quarter, and it shouldn't be too different from first quarter of 2023. Now, 2022 is a different ballgame. 2022, you had all kinds of, inflation within the system. So what gives here? So I showed this to Marcus last week. If you look at, put up slide 3, here's what I did here is I took the actuary data from the Office of the Actuary, and I created a model using Treasury outlays. And I looked at, okay, how much money is going into Medicare Advantage? How much money is going into fee-for-service? Using the fee-for-service outlays from the U.S. Treasury, it's kind of like a cost number. Because if it's fee-for-service, that's sort of the cost level you would expect a Medicare Advantage plan to pay, maybe a bit lower. But as you can see from this, they're neck and neck. In other words, what Medicare Advantage can convince a hospital to take in terms of payment for the care of a patient isn't much different from fee-for-service, and that creates a conflict. And it is perfectly sensible when you see all the heat, all the pressure on Congress to do something about prior authorization rules, about network requirements, about marketing, brokers. We've seen all of that in the last 12 months, and it is almost all emanating from the hospital systems. They are all talking about it. It's not, you don't hear doctors practice. They gripe here and there, but you don't see it. So the pressure, when they talk about benefit expense, pressure is really coming from the hospital systems. And I know we're going to talk about that in a minute. And that isn't to be extrapolated broadly, because if you look at the next slide, it's a different story in Part B. And here I did the same basic exercise. I took what I estimated what the Medicare Advantage would be getting for Part B services, because the Office of the Actuary separates those. And then I looked at a fee-for-service estimate. And as you can see, the fee-for-service number is decent, about 19%. Not coincidentally, between the Medicare Advantage and the fee-for-service level. And if we could treat the fee-for-service outlays as kind of the cost basis, you could see that Medicare Advantage plans are having a much better relationship with the Part B plans. And for that reason, we've seen a lot of pressure to move care into the outpatient setting. You've seen hospitals respond to that by trying to be as outpatient as they can, by setting up outpatient facilities with facility fees and all these tricks. And really, it's this war, but that really isn't going on with Part B, which of course is Part B is your physician's offices, it's lab work, it's durable medical equipment, and that sort of thing. So this exercise, I think, kind of isolated what the issue is, which is helpful, because as we think about, this being a systemic problem or a long-term problem, we can understand, all right, this really comes down to how Medicare Advantage plans are working within their markets and specifically with their hospitals. And I'll also add, this is top level data. This is not UNH, and therefore it includes all those little plans, that don't have a lot of stroke in their markets, and they're having to fight it off with the hospitals. So
let me zoom out and see if this rephrasing is accurate. The Medicare Advantage market is about to peak, and in public markets we look ahead a little bit. So it's basically at the peak and going to be declining if you take a 1-2 year forward look.
In terms of enrollment, yes.
In terms of enrollment, but enrollment would eventually drive payments, wouldn't it? Like if you have fewer people enrolling, that should reduce the overall market size. I would think.
You're not going to have fewer people yet. What you're going to have is the growth of the number of people slowing. So if you've got to turn in, growth numbers in the enrollment metric of 8-9% a year, that gets tougher and tougher to do. So separate that for a minute from what you're getting per head. Your first metric is, are we attracting and keeping enrollees? So it's not going to go down.
Okay, so it's not a shrinking market, but it's not growing as quickly as it has previously.
Yeah, and it will. In a few years, it will shrink because that 1947 cohort is going to die, and that the cohorts that came after 1947 are smaller and smaller. So eventually, yes, you're going to hit a trough. But right now, where you are, and probably until 2028, 2030, you're just in a slower growth environment in terms of enrollment. But again, I'll just restate, there are a whole lot of plans out there that are going to go by the wayside before you ever see the impact on a UnitedHealth or a Humana.
Right. So the competitive dynamic between the plans and each other, and then also the Medicare Advantage plans and the health systems, hospitals and health systems, that's going to get much more pressure between those groups for competition.
Yes.
And I think what you're showing on the previous slide is that the Medicare Advantage plans are sort of holding their own, putting more of the pressure onto the health systems, and they're able to maintain their medical loss ratio, at least so far, even though it's early days. Is that right?
It looks like they're maintaining their medical loss ratio in that mid to high 80s range by having more margin in their Part B, in their Medicare, in their outpatient physicians payment, which they prefer anyway, right? And patients do too. And the hospital utilization and the price of the hospital utilization, may be a loser for the plans, or certainly it's not a winner. And they try and do as little of it as possible. I think that's the way to think about it.
And then you kind of mentioned that United, because of all the disruption with Change Healthcare, they cut back on their utilization management tools, and yet they still had a medical loss ratio of 84% and change.
Correct.
Strikes me as pretty good, even if they turned off some of their utilization tools.
Yeah, that shows you it shows you potentially that maybe some of that utilization management isn't necessary. Because the utilization management could do a couple of things. It can deny care because you don't qualify, or it could just slow that train down. And it looks right now that it didn't have a material impact on their Medicare loss ratio. I should disclaim this, Vic, and tell you that every analyst on Wall Street, and including some of UNH's largest shareholders, have very little idea what goes on underneath that hood. So, there's a bit of mystery to it, if you will.
Yeah, I mean, UNH is a pretty big ship, and they're very sophisticated at managing their own numbers for Wall Street, I think.
Yeah, they have a lot of tricks in their trick basket. And if we, on the enrollment side, if you go to the last slide I brought with me, Marcus, using the enrollment metric, what's happening is that a lot of the plan sponsors are trying to push enrollees in the standalone prescription drug benefit. So you would pair your prescription drug benefit with traditional Medicare. What the plans are trying to do is push people out of the prescription drug benefit into a Medicare Advantage plan, which also includes a prescription drug benefit, which is putting downward pressure on enrollment in traditional fee-for-service, but creates, if you're not UnitedHealth Group and you have your own, large, robust, standalone prescription drug benefit, or your CVS, okay, you have access to those customers, you have a good pitch to make to those customers to move to Medicare Advantage. So you've got some room to run in terms of taking people out of standalone PDP plus traditional Medicare and moving them into Medicare Advantage plus a PDP plan. You have a lot more. You've got a lot more leverage there, and so we should see them take advantage of that in their enrollment metric. And again, smaller plans, fewer members. That's really not the case, and that's where it's going to get kind of sucked out of.
Yeah, and is it because the prescription benefit as a standalone is really hard to manage for a payer, so they want to bundle it with the medical expenses?
Yeah, under the Inflation Reduction Act, the benefit design was a new benefit design is being implemented in 2025. It requires the plans to take more financial responsibility for people with chronic conditions and high cost drug utilization, which means that you need to have better insight into their utilization and their care, so you can intervene and try and get that patient, working with its doctors. With a standalone PDP plan, you can't see anything. You just get the prescription and you pay for it. That's it. So that's what's driving that. And it creates a political problem, right? If you're, Senator Sanders from Vermont, for example, or Senator Klobuchar from Minnesota, you believe wholeheartly that fee-for-service, the traditional direct, which it's not a direct program, that's the mission and role of the government, and you don't want to see this privatization. And this is going to make you very nervous and unhappy as it plays out.
Can you just unpack a little bit more the Part A versus the Part B, and sort of what that tension is there between the managed care organizations and Medicare Advantage and the hospitals? I mean, so for anyone who's listening and not viewing, the rates were very, very tightly coupled between Medicare Advantage and fee for service, and obviously there's a higher burden in a Medicare Advantage model than there is in a fee for service model. But at the same time, the enrollments are now over 50%, right? Medicare Advantage. I mean, not just the prescription drug plan stuff, but Medicare Advantage, even though it is decelerating in its growth, it has become the dominant model for senior care in America. And so that would seem to create situations for hospitals in more than half the cases when they're caring for seniors, and that's really expensive care, where the burden of care management is higher for them. Rates are no better than they would get for fee for service. But what else is going on there from a tension perspective?
Well, what you have with the health systems in America is, one, first of all, it's consolidated a lot. It's not as consolidated as people like to think, but it's definitely consolidated and over the years. And typically in a market, unless you're talking about Houston, like a really fast growing area, you have, or Nashville, because we're home to a hospital company. You have, usually you have two hospitals, and some places you only have one. So in the markets, the hospitals are very much a dominant player, a definer, if you will. And you cannot say to your members, we're not going to put Vanderbilt on our network, right? You can't do that. And Vanderbilt, of course, knows that. Just to pick on Vanderbilt because they're local, and of course they know that. So you have to put hospitals in your network that attract members and keep members. That's your first consideration.
Yep.
Then those hospitals have to get rates that can keep your capitated payment, where you want it to be in order to also be competitive in your market. And it has gotten very, very difficult. And one of the reasons for that is labor costs. If you look at the way in which labor costs took off in 2021 and throughout 2022, the curve is a lot steeper in hospitals than it is in doctor's offices. Why is that? Because people prefer to work in the doctor's office.
Sure.
So they're willing to take a little bit less of a wage, for the nice predictability of working in a doctor's office. So your hospital systems are, first of all, have a stroke in the market, right? But at the same time, they're very expensive. So you're an insurance company, you got to put them in your network. So what are you going to do? You're going to try as hard as you can to pay them as little as possible while still keeping in their network. And that's why you see in the graph I showed this convergence between fee for service and Medicare Advantage outlays, because you've got one titan basically beating up on the other, and there it's sort of it's a draw right now. And this is why we're hearing so much about, prior authorization and the American Hospital Association trying to get Congress to intervene and all of these things. These are all a result of the insurance companies trying to find that balance between those competing interests. So now when you're talking about Part B, it's primarily physicians. There are 860,000 physicians in this country. Okay. A typical multi-specialty practice, large multi-specialty practice is what, 250 physicians, 200 physicians. If you start getting into the 300-400, that's really large. Well, there's a lot of those, and you don't have quite the negotiation going on that you would have with a hospital. And do people, they want their doctor, they want to keep their doctor, that this is true. And I think that plays out. But does it matter, do they go to this orthopedic surgeon or that orthopedic surgeon? They just met them for their knee, So that's the Part B dynamic, and it's very, very different. And Medicare Advantage plans can take advantage of it, and it allows them to negotiate better prices. It's not as critical in every specialty case that you have every single doctor in town in your network, like you have to have, most hospitals in town. So that's the yin and the yang, and it's hard to know exactly how it's going to turn out, because on the one hand, we're hearing anecdotally that physicians' offices, they're dropping Medicare. And Medicare Advantage is like, this is just too much of a pain in the neck.
I was about to ask about that. So, the word on the street is that innovating in the specialty space in Medicare Advantage has gotten really, really hard, really, really fast. Like,
is that right? Okay.
We're talking like in the last 6 to 9 months. It's very much sort of, word on the street. So, I'm not going to name names or talk about companies or talk about who's struggling.
And when you say you specialty, you mean like orthopedics or cardiac or so forth, right?
No, probably more sort of specific disease states. So, we might be talking
diabetes.
We might be talking about diabetes. We might be talking about cancer, actually, groups who are focusing on cancer from a value-based care perspective. just hearing that there's a lot of headwinds in there. These groups are not big enough to garner articles from the Wall Street Journal, right? Wall Street Journal is going to write about Humana.
Right.
But like, how do you see? It seems to me that you basically feel like, okay, we're going to hear about the rate stuff. The rate stuff becomes effectively theater, maybe to even say, woe is me, and then overperform on a quarterly basis, especially for the publicly traded companies.
Well, say woe is me so you can keep Congress off your back, too.
Yeah. Okay. Fair play. And then also they have the ability to raise premiums, and they have, they have plays that they can still execute out there. And of course, like you never want to just lay on your back and accept sort of poor rates. I mean, you always want to sort of posture and say, I'd like better rates. But at the end of the day, somebody gets impacted and gets hurt. Vic and I, we're always trying to, the reason why we study all this stuff is so we can understand where to, make investments. And so Medicare Advantage was a super popular space for, probably 5-6 years there running straight. And now it's starting to get kind of cold in the VC markets. So is that something you would expect based on the data analysis that you've done here recently?
And since you guys kind of run ahead of us by a few years, I think it's an a really important point, because and I would guess that a big driver of that is the demographics. Having no longer being a growth area. I think it's stupid not to innovate. When you have scarcity, that's when you're supposed to innovate. And it could be that thinking about that innovation needs to think more about scarcity, demographic headwinds, making sure docs can take Medicare Advantage, but also practice medicine. Those are the kinds of things that everybody should be thinking about, because at some point, the game plan for Medicare Advantage has been, let me get as many people on these rolls as possible. And eventually it's going to be more about profitability, more about preserving margin. And that means you're going to have to make sure that everybody who works for your plan, either as a doctor or, whatever, they have to be as efficient as possible.
Yeah. So it's kind of interesting that the health plans, Medicare Advantage health plans, are negotiating with the health systems, and depending on the market, it might be slight variations. But what you're showing a couple slides back was they're sort of they're negotiated to a draw, right? They're kind of paying roughly the same amount. Mm-hmm. Whereas when you go to the physician groups, and maybe surgery centers, where are surgery centers? Are they in B?
They're in Part B. Yeah, they're outpatient.
Yeah, they're in B. So physician groups and surgery centers, they don't have the same negotiating power. So they're having to accept a lower rate in Medicare Advantage, or they just opt out altogether, which is maybe worse. Definitely worse for the patient, but it's not as common that someone would not enroll in Medicare Advantage because a particular physician group had opted out.
Especially if it was a primary care physician, you would care. If you say you have a chronic disease and it's your endocrinologist and they're not in the network, you're going to care about that. Are you going to care about the guy you're going to see for a few minutes before he replaces your knee? Probably not. And that
probably not.
Yeah, and it's I think there's a difference in patient choice there. The other thing that I think I just want to bring up is, if you're in Medicare, the physician group is typically moving away and not accepting Medicare at all in any form. And so if I'm managing a plan and trying to build a network at Humana or United or any plan, there's really not any alternative that is very scary. Like, if, I need to get my share, hopefully more than my share, of the Medicare Advantage population. But if this doc abandons and isn't accepting anyone, that member is not going to go to another Medicare Advantage plan because of that, because they're not accepting Medicare at all.
Yeah, that doctor wouldn't. So that patient has a choice of going concierge, which is typically what we'll see. We'll see a doc okay, I'm done taking the insurance thing and that across the board. And then he'll say, I'm going to be, send me $2,000 a year and I'll be your concierge doc. That's becoming more popular. Or that patient has to go find another doctor, which is never ideal. But that's kind of I think the world we're going to be living in here as this tension continues to get tighter. But you're seeing it first in health systems, hospitals, before you see it in the doctor, down on the corner.
Right. So, Emily, we've been following various reports, sort of measuring and mapping how much CMS pays for pharmaceuticals. A couple weeks ago was the GLP-1s. Last week it was the Alzheimer's, and it's in the multi-billions per year and rising pretty quickly. And I wanted to circle back to talk to you about the ongoing sort of evolution of where FDA's mandate is versus CMS's mandate in a new drug that comes up and shows a lot of promise. First of all, how do you think the agencies ought to be set up, or how were they set up in the legislation? And then how do you think it's evolving today? Because it seems like there's a transition there.
Yeah, you're seeing a paradigm shift, as it were. And the paradigm shift is brought about largely by the Inflation Reduction Act, which included provisions that were to control the drug spend, the Medicare drug spend. And those provisions include one that allowed Medicare to negotiate with manufacturers on top 10 drugs in spend. This would be things like, Eylea not on it. Xanda, I think Xandi is one that's on it, and negotiate those prices with the drug companies. It's a squirrely provision. I'm not sure it stands up under scrutiny from the courts, because the penalty for not negotiating with the government is a 95% excise tax on sales. There's a reasonableness to all this, and that I think most people would consider unreasonable. But we'll see how that goes. That's being played out in about half the courts in the country, from what I could tell. Then the other provision was an inflation cap. This has been true in Medicaid for years. So this is nothing new. Everybody knows what to do with it. All it does is push the launch price of the drug up, and from there on, it gets to have inflation, basically inflation, which right now is pretty hot. So those are the two provisions. But the message from the Biden administration, and they've gone on the campaign trail with this, is we're the first. We've controlled drug prices with the Inflation Reduction Act. Well, that's great until the headline, on the nightly news is Ozempic will cost you $1,300 a month. Now, it doesn't cost you $1,300. It doesn't cost anybody $1,300 a month, but that's the headline. The Alzheimer's drug Aduhelm was priced at $56,000 a year. Okay, these are problems of perception, but when you are in politics, you have to care about problems of perception. And so the problem there for the White House is, wow, these fancy drugs are coming through here. They got big numbers on them. People are going to think we didn't actually control the drug spend with the Inflation Reduction Act, because they're getting hit with these headlines. So that's the problem. Okay, so what's the solution? As far as the FDA is concerned, they don't care. If a drug meets the requirements of safety and efficacy, and we'll get to that efficacy part in a minute, we don't care. 51% of their budget comes from the drug industry. They don't approve drugs. They don't have a budget. I'm not saying they approve drugs they shouldn't. They just, if they stop approving drugs, they don't have a budget. It's why they're there. So that runs counter to CMS's position, which is we need to control the drug spend. So, okay, what's the solution? FDA is not really playing ball. They are approving drugs because they're safe. Efficacy is getting a little loosey-goosey, which is CMS's complaint. Like take the Alzheimer's drugs, where you said this is safe and there's safety and efficacy, it's passed the test, but we've got some pretty significant side effects. So what CMS is doing is grabbing those side effects and say, all right, Medicare's only going to pay for it under these restrictions. And those restrictions were pretty strong, mostly only going to pay for it in a clinical setting. So along comes Ozempic, safe, it appears. Efficacy on weight loss is fairly well documented, but you can't cover weight loss drugs, health Part B drug plan sponsors do not have to cover weight loss drugs, and they have chosen since the law was passed over 20 years ago not to do that. So the position on the weight loss drugs is okay. They work. It looks like they're pretty safe, but Medicare won't cover them. All right. So the drug company's like, well, how do I get Medicare to cover them? All right. What I do is I do some research and produce a study on this drug doing a good job on cardiovascular disease. If you take Ozempic, you are less likely to have a major cardiovascular event. The difference is not huge. The placebo was 8%, Ozempic, or no, Wegovy, 6%. That turned it into 20% improvement. but you're really pretty low base numbers. So CMS is like, okay, very expensive, same problem. Big expensive drug approved by the FDA. They say it's safe. It meets the test of safety and efficacy. We're supposed to be controlling spend. Right then, Part D plans, you can use all of the tricks in your utilization management basket to control the spend for the cardiovascular indications. And that's how they're managing through it. And it's getting kind of funny, actually, because they're like, what do we do? And it's a huge departure from many, many years of FDA approves, CMS pays for it. Okay, no questions asked.
Yeah, and I guess the thing I'm struggling with is it seems like CMS has assumed this mantle of trying to make a value decision of this drug is worth paying for because it has better efficacy than the side effects are negative, or something similar to that. First of all, is that what they're trying to navigate?
I would say that they're walking towards that line. They're just not walking over that line. For example, Aduhelm had some pretty important side effects. Bleeding, brain bleeding, for example, hemorrhaging.
Mm-hmm. That's a big one.
Yeah. And CMS said, all right, that drug was approved, but we want that administered in a clinical environment. We want, and they did this with the follow-on drug. We want registry. We want to know who's taking it. We want to have post-approval information about this drug, which, by the way, the FDA has and can require. The FDA has just been really, really bad about collecting post-approval information, largely because they can't do anything about it. If a drug doesn't perform post-market, the drug companies really have to voluntarily withdraw it. So what CMS is saying is, okay, kind of safe, kind of, efficacious. Let's get more information. That's kind of what they're saying. They're not really crossing the line and trying to substitute their judgment for the FDA's, which is what they need to avoid doing. But they're coming awfully close to it, and that's a political problem. I mean, it's politically motivated more than it is anything else. And what could transpire here is we could have a real all-out war between these two agencies, where the CMS actually starts putting its feet in the shoes of the FDA. I don't think that's going to happen. I think they're going to play these games and hope for, drug approvals that aren't so expensive.
So one of the questions I had is the nature of some of these therapies, and I think this will be the case more and more as more and more cell and gene therapies do make it across the line. We're kind of backlogged at the moment, but at some point that's going to all open up. We had the CRISPR thing with sickle cell here recently, right?
Right. Now, keep in mind, Marcus, when a drug is the real concern is not just the expense of the drug; it's the expense of the drug times units. So, Alzheimer's, a lot of units. Weight loss, a lot of units. A very rare genetic disease, not a lot of units. So just I forgot to mention that earlier, but go on.
No. That's an important point. So in fact, it's relevant to what I'm going to ask, which is, it seems like we've had decades of therapies that improved the model of care that clinicians plus technology can deliver to patients. But now I think everyone is hoping we're on the precipice of therapies that can relieve the need to have certain models of care entirely. And so, talking about the GLP-1s and chronic kidney disease and, sort of what the specter of this whole class of drugs is doing to DaVita, for example, right? I realize this is kind of it's a new thing. It's got to play out for a very, very long time. But is that something that CMS is considering or thinking about? Like, do they incorporate, hey, if this thing does actually, get the kind of proliferation that we're modeling, that could have cost savings in dialysis or other things like that?
There's an attempt to do that mostly in the Congressional Budget Office, not the CMS, but the Office of the Actuary does that sort of work. So if evidence is presented about cost savings from cardiovascular disease, which is where we've got the indication outside of diabetes and weight loss, that is something with good research and evidence. And I question it for cardiovascular disease, but let me get to one that I think will really matter. That can make its way into the Office of the Actuary's projections. He will talk about that. He will write about that, and that will tell us, that will give us the signal that we need. One of the interesting things about the GLP-1 drugs, and this is actually, I think, more important than what it might mean for weight loss, dialysis, cardiovascular disease. And that's a study that was released, I guess it was a week and a half ago, on what GLP-1 drugs do for mental health. So there is a way in which the brain processes and uses glucose that is controlled by the GLP-1 drugs, and all we have is mouse data. Okay. But there's a lot of ongoing research about the role of gut health and mental health, which you probably, because you're into wellness, you both are, you probably have heard about, right? And anecdotally, if you know a trainer or somebody who's in really good health, they know this, they talk fairly confidently about it. But now there's a lot more research going here. So if you have a drug, the GLP-1 drugs actually have a positive impact on a serious mental health condition like schizophrenia, taking that patient from somebody who cannot function to a patient who can go to work, that could be a really big deal. Or somebody who doesn't crash into the ER, once a month or whatever. So, so the answer to your question is yes, that gets studied, but probably not on the time scale that your typical, Wall Street buy-side analyst is going to do, but possibly over the long term for, other investment considerations, like venture in particular.
Okay. Well, we need to keep watching that, because I think CMS and FDA are so critical to the industry. This evolution is going to make a big impact over time. It's a slow-moving train, but it feels like it's changing.
Yeah, for sure. So. All right, last point.
Yeah, last point. So the Senate has begun to make noises around assessing whether nonprofit hospitals or untaxed hospitals should be relooked at. You brought this to my attention. So talk through, how real is that, and what's the process they'll go through?
It's real in the sense that most of the conflict between nonprofit health systems has been with local governments. where we had a situation in Morristown, New Jersey. The latest is in Pottstown, Pennsylvania. That was last year, where the local government is looking at its tax rolls. It's got a big hole created by the local hospital or the local health system. And it starts asking questions like, well, how much charity care do you do? Why are you sending wage garnishments to patients who couldn't pay? And all those questions. So there's actually a hospital in Pottstown, Pennsylvania that lost its local tax exemption that would apply largely to property taxes. And so that I think was the first one. So it hasn't really happened a ton, but I will tell you that last mayor's race, I had quite a few conversations with candidates asking that question. What about that big hole in our property taxes there on 21st and West End? So not to suggest anything here, but that it's on the mind, right? So what the Senate, what has the Senate's interest is the income tax exemption created by the federal 501c3 statute. And what they're asking is not the health systems, how much charity are you doing? What they're asking the IRS is, what do they have to do to be tax exempt? They just need to file a 501c3 approval and get approved, or is there something more to this? And the fact of the matter is the IRS doesn't have a great process. They don't have guidance on it. They don't have due diligence on it. So and this is coming from the left, Bernie Sanders, Amy Klobuchar, to name a couple. But Stat News 2 days ago published an op-ed from Marty McCary at Johns Hopkins, who has become a leader on evidence-based care and, pricing and so forth, saying basically the same thing. This really needs to get a good look. So I think that it has legs in the sense that the IRS will be called to task to manage their oversight of the 501c3 exemption and express what those standards should be. I think garnishing wages, is definitely going to be off the table. If you're going to be a nonprofit hospital, there's probably a few other things that Marty McCary listed that I didn't know were going on. And I think it's kind of where it goes. But, and the larger lesson here is that nonprofit hospitals have kind of stuck their neck out maybe a little bit too far when it comes to, their no offense to anyone, venture funding, for example. That might make a lot of sense internally. That doesn't make a lot of sense if you're a member of Congress and
the optics on that.
Yeah.
The optics on that are just not great. Yeah. Yeah, I get that. I get
the optics of a nonprofit health system having a large portfolio of money in venture capital growth assets, or a bad actor like I think Steward Health, where they sold property, to fund salaries and ongoing expenses and didn't really use the money in any way that benefited, the community that much.
Yeah.
Sent it to Birmingham.
Yeah, Yes. Okay, well, we'll have to watch that. I think it's going to continue to be kind of a hot topic over the next 6 months or so.
Yeah, I think it'll probably endure longer than that, but it will embolden local governments. I think that will definitely probably come first, and then I think the IRS sets some standards, and then the nonprofits are going to be in that position where they're going to have to say, all right, can we meet these standards? Does being for profit make more sense here? Considering these are all, we don't know the answers to these things, but those are all the next questions.
Wow, that's a big deal.
I mean,
that's a big deal.
Huge deal.
Yeah. I don't know that there's that many nonprofits that could manage that transition.
It would be a very different environment.
Yeah. That combined with the grant funding sort of declining over time is going to be really hard. The academic medical centers really are the recipients of that probably. So,
all right, Emily, thanks. See you in a quarter.
Okay, thanks you for having me, and I look forward to seeing you guys again.
All right.
Great, thank you. Bye.
All right, bye.